Environmental emergencies. We're going to start with some fundamentals about heat transfer and then just thermoregulation in general to get some of the vocab kind of nailed down, because at the end of the day, that's largely what we're talking about, is just heat. It's interesting, right? Heat, like cold isn't really a thing, I guess, right? Much like darkness isn't a thing. They're the absence of something else, right? And so things can be colder than other things, but arguably aren't cold, right? They can be less heated, I guess. Now, we're familiar somewhat with the etymology of the breakdown of this word, thermo meaning, heat, referencing heat, and then genesis, which is to create, right? And so largely your emergencies here in regards to these thermic problems are going to be regarding, can you make enough heat, or are you able to excrete or release enough heat, because too much is a bad thing. But this, like everything else, we just kind of fall in this Goldilocks zone, right? Not too much, not too little, or you die. The hypothalamus is a part of your brain that works largely like a thermostat through, what are they called? Not baroreceptors, thermoreceptors. They're literally measuring amount of heat, right? And it will send signals saying, we're too hot, we're too cold, don't eat the porridge. Now, one of the most significant things I think to understand about thermic injuries is what they do to, or thermic conditions, is what they do to your blood vessels. Put very simply, if you are too warm, we will have vasodilation, which is going to allow our fluid to move, come in more contact, and allow more heat to escape. Our body is going to sweat through the process of evaporation cooling us down. On the inverse side, we need to generate heat if we're too cold. And so our body will constrict the vessels, shunting it away from our extremities and our skin for sure. And then through the process of metabolism, we'll generate heat. Because one of the other elements that we haven't talked about in regards to cellular respiration and cellular metabolism is, sure, we're talking about glucose breakdown into pyruvate, we're talking about ATP, we're talking about oxygen combination and these creation of sugar. Do you remember the sugar composition? Wait, no, I got it. It's 6-12-6, right? Yeah. Carbon, hydrogen, oxygen? Cool, fun. With that combination, essentially in the breakdown, yes, we get ATP, but we also get water. We also get what? Sugar plus oxygen equals energy, water, and CO2, right? That's where our exhaust is coming from. The one thing that we haven't talked about in that process is heat, that is generating heat through metabolism, right? And so essentially, that's what the shivering is. The shivering is your body forcing metabolism, not because it necessarily needs the energy, unless you argue that the energy is necessary for the shivering, but mostly because we're trying to generate heat. So again, when we're having emergencies like this, it's all a question of, can you ventilate yourself? Or maybe I should be careful about using the term ventilation. Can you release the heat appropriately? Or can you generate the heat appropriately? And what will happen here is there's all kinds of different things. Like alcohol makes our blood vessel constriction more difficult. Why it's not uncommon to see gentlemen who are in between residences outside who are drinking alcohol and then having hypothermic injuries, because not only is it cold out there, but the alcohol is preventing their body from working the way it ought to. Now, heat transfer is largely broken down into these four things: conduction, convection, evaporation, and radiation. One thing that I'm realizing now isn't on there, but probably deserves its own slide, is respiration. Respiration releases a decent amount of heat as well. Give you a second to write all that down. This is the most concise way I could think to describe these things, and some of them are often confused. Boom, 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 landed.
For radiation, is that kind of like you open the oven door and you just feel heat on you?
I think so.
Okay.
It's like the sun. The sun is radiating heat. I'll show you in a couple examples. I can and I will. And I don't know if you should know it from grade school. It took me a decent amount of reading to figure out.
Grade school overcomplicated.
Yeah. Put pretty simply, conduction requires solids and physical contact, right? And so I'm solid, Aiden's very solid, right? I'm conducting heat through those two solids directly contacting. So if you said, well, no contact, no heat, I'd say, no, that's not entirely true. Firstly, to just talk about radiation, I can heat him up because I'm radiating heat into the room, and that heat is affecting him. That's radiation. I'm heating up the room, the sun's heating up the earth, but it's not direct contact. Evaporation is sweat turning into vapor, right? So I've got a liquid, and as essentially that evaporates, it's going to help disperse heat. Convection is literally the movement of air or liquid past it. So sweat is not convection because it's evaporating. It's turning from a liquid into a gas, and that process is causing heat exchange. But if water was running down your arm, it cooled you down, that would be convection because the liquid is transferring the heat. If you said, well, isn't convection kind of just like conduction for gases and liquids? I'd say yes. Conduction is solid contact. Convection is gas and liquid. Landon?
This is about heat produced during metabolism.
Yep.
Is there a numerical value that we should?
There is. It's called a calorie. Yeah.
So, like, if you have a pot that's boiling water, the steam or whatever coming from that, is that radiation or evaporation?
Evaporation, I think.
You know, like the pot on the eye would be conduction.
So if you said, okay, I'm going to take a heat stone, like they used to in olden times, they'd heat up they'd put a stone in the fireplace, take it out until it got cool enough to be safe, and they'd set it in their bed and it would help heat it up. Well, it's a solid, essentially touching a skin would be conduction. The fact that that heat is radiating heat into their blankets is a different issue. The fluid conducting the heat, or I guess I don't want to use that word, but the fluid transferring the heat is convection. What I can assure you is that we probably don't need to spend a ton of time on this stuff. If you can make the simple association that if I said, how is heat transfer done from solid to solid? You said, what? Conduction. If I said, okay, but now it's transferring into you from either air or liquid moving past you, you would say convection. If I said if it was something changing the state of matter, right, or not something, specifically liquid changing its state of matter, we would call it evaporation. So what you got to be careful about there, and I don't know if I have a question like this, but this is the tricky question I would write, is I would include a conversation of liquid and have you discern between convection and evaporation. It would say something like, you know, you are, if, you know, sweat on the skin is the changing of a liquid to a gas, what is that? And you would have to say, oh, well, that's evaporation specifically, even though it involved the words liquid, which is often referred to in convection. Anybody ever done hammock camping? Right? Gets real cold, doesn't it? Why does it get cold? Because you have convection stealing heat from you from underneath, right? The wind blows under and over you, essentially. Yeah. So heat transfer on conduction might be something like laying on the cold ground. This will be some fella, a hunter sitting on a rock. I feel like that's like the quintessential EMS example. Or a person laying on the concrete. The reason why this whole conversation is in any way important to me is, number one, if you didn't already know that evaporation and sweating cooled you down, you definitely need to know now. Number two, it's kind of like several of the things that we talked about in the past. I know you know that because it's cold out, that's not good for a body. It's worse than you think. That's the point. It's worse than you think. It's not just that it's 27 degrees out. It's the fact that he's also laying on a thing that is a solid and physically transferring heat out of him. It's also the fact that it's windy out today and that convection is blowing across him and also sapping. It's not just 27, it's probably to him 7 degrees because of all of the other processes eliminating heat from them. And be under no illusion here, it doesn't have to be a Michigan Flint street to be super cold. I've seen hypothermic injuries for people in their basement. I know you don't have a lot. Basement is a thing that you dig underneath your home. We got them in Michigan. It's like non-existent here in Georgia. But the idea is essentially is that even an elderly person in a somewhat cool environment can still suffer hypothermic injuries. Be careful of that. Now let's talk hypothermia. Look at that. Isn't he cute? What's he holding? It's a lamp? Well, I don't know what it is. I was like, when I put this up there, is a bunch of students going to be like, Mr. Fearon, that's a drug? Or whatever. I don't know. I have no idea. I've posted a meme or two up there where it didn't mean what I thought it meant. I was nervous about this, but
It's like one of those earthquake things. You know what I'm talking about?
I do not.
Yeah.
Seismograph? Why is he cross-eyed? That's the real question. Anyways, so here's the most fundamental, simple version. If you look in your book, it'll give a chart, and that chart is on the next slide, minus the confusing part, or the most confusing part. This is the real discrimination that I need you to make. I might ask you to differentiate hypothermic injury based on the temperature. I can assure you, I don't remember those numbers. So what I mean by that is if I have a test question on it, and I give a temperature, the temperature won't be the only thing you should be using to determine what level of thermic injury he has. Because again, I don't remember either. I remember 2 numbers. I remember 95 and I remember 86. Does anybody have any idea why I know those 2 numbers?
Below 86.
Say it again.
Below 86 is hypothermia.
Kind of. I mean, yes. Yes. You'll find out here soon. But those are the 2 numbers. If you fall below 95 Fahrenheit, we call you hypothermic. And if you fall below 86, that means something else. Now, the most important thing to understand about mild hypothermia is that really your mentation is just changing. Like you are starting to divert your energy, thought, and resources to staying alive. 95 is very cold. That will make you withdrawn, but won't really cause altered mental status. We should expect these people to be communicating with us. Why are they shivering? Trying to produce heat, right? What do we call that in a fancy way? Drives girls crazy. That's what's doing it. It's called thermogenesis. Y'all need to read your books more. It's this old dusty book about a dude and a chick, butt naked. It's called Genesis. They both play the drums. All right. At a certain level, it will be defined as moderate hypothermia. That's where we're starting to see mental status changes. This means not just anxiety, but confusion, disorientation, and in its most extreme sense, altered level of consciousness, which is a far worse issue. Then you'll start to see bradycardia and bradypnea. What does that mean? Say it again. It means the exact opposite of that. What would a sign of compensation be?
Tachycardia.
Tachycardia. What's another one? Tachypnea. It's a sign that they're fighting the fight, right? Which means that if we are down to the point where their heart rate is slow, that their breathing rate is slow, it can be a major, major issue. You gonna ask me about bradycardia? Oh, go ahead.
If you're in hypothermia,
Hypothermia.
wouldn't you be shunting and also hypoperfusing as well?
Yeah.
Does that
Well, it depends on your level.
Does it occur in mild or is it mostly moderate and severe?
If the question is will hypothermia lead to hypoperfusion? Yes. The issue is though in the mild sense, we're shunting very intentionally away from non-essential organs. So hypoperfusing, yes, but you're not perfusing well in your skin is where we start. At a certain point, your body cannot keep up that effort essentially, and then we'll start scaling down for sure. But I would expect that more in moderate, because put pretty simply, if you can remember our compensation triangle, essentially. I mean, hypotension comes before bradycardia and bradypnea. Like Usually you're going to be tachycardic and tachypneic to keep your blood pressure up. Then it can't do it for long, so your blood pressure starts to drop. Then essentially, because you're no longer perfusing, you start to see these things, which means in a sense, if I'm seeing these things, I might already be hypoperfusing. That's how severe it is. Or that's how, I don't want to use that term, but that's how problematic it is. The issue with that is that when we chill people, because you don't want them to go bad, but when you are essentially suffering hypothermia, it's not necessarily decompensation, it's lowered metabolic processing. Like you're literally slowed down. So, but we treat it largely like it's shock because we can't differentiate it. Okay. The severe is chance the altered mental status is now becoming wholly unresponsive. This is where we're going to start to see our dysrhythmias and cardiac arrest. It kind of like, this severe hypothermia is a very narrow window in a sense. Like you won't often see people in that category. You will likely either see them in moderate hypothermia or in cardiac arrest. You know, like you're going to come up and be like, oh, he's dead. I wonder why he died. It's cold out. That could have done it, but you're just not sure. And so it's going to be rare instances you check essentially a temperature and find like, whoa, it's 81. I think that we're in a major issue. Usually you're getting called because you're seeing them scaled down or they're super dead. In Michigan, in fact, because we had such harsh winters and stuff, it was always come springtime, all of the snow would melt and all the homeless people that no one could find because they were covered in snow and died. So come springtime, dude, we'd be scooping people up off the streets left and right. Yeah.
Does our cardiac arrest protocol change if they were hypothermic?
It does, and it changes at 86 degrees.
Okay.
Which is why I know that number. Excellent question. This is part of the chart in your book. I snipped out a portion there. The more true you want to be about a thing, the harder it gets to understand in many cases, right? What I mean to emphasize here are the changes that we can note without ever taking a temperature check, right? This will be how you, not really going to largely affect how you treat your patients. It is going to be how you get questions right on the test, though. Because if you can remember the degrees, you're fine. Chances are that's going to be tough. Remembering their presentation can be helpful, especially since getting a tympanic temperature is very different than getting a core temperature. In any event, if they're still shivering, we will count that as mild hypothermia, or what I would refer to as they're able to fight the fight. They're in a form of compensation. This will lead to them being withdrawn. This means essentially that their vessels will start getting constricted. We would expect more of a tachypneic situation than bradypneic. Rose?
Is that how we've all had hypothermia? We've all shivered?
No. It's not that you only shiver with mild hypothermia. It's that you can still shiver through mild hypothermia. So I bet that if you popped your hoodie off, you might get cold enough to shiver, but your temperature's still probably 98 degrees. But you would still continue to shiver until approximately 90.
So are these temperature ranges core temperature or tympanic?
I don't know. I know that we can't check core temperature. Right. I am viewing them like tympanic, but I don't know and hadn't considered until I said it earlier. Yeah.
If they die in a cold place, do we move them and then start resuscitation efforts, or do we?
Yeah, basically. Like if a guy is in the middle of a wintry snow and cardiac arrest, we ought to get into the truck.
So you will move him first?
Mm-hmm.
Okay.
Well, it would depend on whether or not I can heat his area, because they have things like heat tents and stuff. But let's say you and I, literally, it's snowing out, it's 15 degrees, and we walk outside and there's a dude laying in the street, cold as to be. I'm like, grab him, we're going inside. And you're like, whoa, but he doesn't have a heartbeat. And I'm like, it's because of the cold, though. It would be like saying, don't stop that infusion of heroin in his vein. He's got a heartbeat. I'd be like, no, please pull the heroin out.
Yeah, because I would think if you bring them back just then and there, and then you move them, like you said, just rhythmia, you guys can.
Yeah, largely. I mean, though it's not that uncommon. We work most of our cardiac arrests without ever fixing the problem.
When's he dead? When's he? I'm not gonna work him.
If I work him for 20, 30 minutes and his capnography is low enough. Does that answer your question?
How do you know if it just happened?
You don't. We'll get into that, though, about being cold and dead.
Yeah.
If I don't answer it, just ask again, okay? Alanis? Well, the only way you're going to have is probably tympanic unless you have an oral temperature, and that can be difficult on an unconscious patient. So the only thing you'll be able to do is that. Otherwise, we're talking different ways.
For cardiac arrest with hypothermia, what are the chances? Like, do the chances go
Up.
way down?
Up. Your survival, yeah, with hypothermia, yeah, absolutely. Because when I put you on ice, it slows you down.
Okay.
So your lactic acid buildup is no longer, your anaerobic metabolism isn't going crazy out of whack, even though hypoxia is occurring. That's kind of where Rose is going to, I think, which is, this is a pet peeve of mine. People use the statement, they're not dead until they're warm and dead, and that is very specifically about hypothermic emergencies, not just a general statement about death. The amount of times I'd walk in, some dude essentially would shoot himself in the chest and be down the ground or whatever, and they'll be like, hey, we need to work this guy, he's cold. I'm like, that's not how that works. He's cold because he's super dead. And they're like, but he's not dead until he's warm and dead. I'm like, it's 30 degrees in here. What are you talking about? I'm like, no. That is what they're trying to get at is when I put you on ice, or when you put yourself on ice, you slow your metabolic processes down, and it will take you longer to die. Which means that if I've got a guy in a submersion injury, because cold water through all kinds of issues will, convection and the like, will sap your heat, that we actually would expect a longer survival timeline if you're cold. So they don't want you being like, boom, it's been 20 minutes or whatever, and it's like, careful, if he was cold, he might have a bit longer.
Is there any chance that as you're rewarming them, the heart kickstarts on its own, or does it need?
Not from a zero.
Not from a zero?
Yeah.
Okay.
Because you're not moving fluids and you're not moving it can be highly, even less effective because you can't move the oxygen because you're experiencing vasoconstriction, or you're not moving the fluid and you're not metabolizing at an appropriate speed. So at the end of the day, all this comes down to a conversation about electrons, and put pretty simply, they're moving slower because it's cold.
Okay.
This is fun. I didn't expect to get this into thermic injuries. It's fun. Nerding out. Now you can see as we kind of shift into moderate hypothermia, we're starting to see a declination of capabilities. Either it's slowing us down because it's so cold, or we simply can't keep up the fight. And that's where we're really starting to see our altered status. Over here, it gets a little tough for me. They pretty neatly put these things in moderate, I guess. This would be a much more convenient chart for me if it just had 3 columns. So I'm probably not going to ask you something in here necessarily. Could I do that? Your patient has... Yeah, I don't think so. I think if I was looking at this chart trying to study for it, I would be like, okay, mild, moderate, severe. And then I'll be asking questions like cardiac arrest versus slow versus fast. That's probably what I mostly will be trying to discern. The real distinction I'll be asking about is, do you know where shivering falls? It'll be I can foresee it. Somebody's gonna be like, that's crap. You said X amount of degrees and blah, blah, blah. And I'll be like, they're not shivering. Or the reverse of that. Your patient isn't shivering because of these cases, but their temperature is that. So you'll need to look into it. But there's that triangle I was talking about. The point is that we have to, and I think this is what Rose was kind of bringing up partly, like, oh, so we've all kind of been mild? I'm like, no, dude, that's cold. Your body temperature is surely never been below 95 unless you were experiencing an emergency. And I put this up here to emphasize, I think, in looking at all of this info, we're like, okay, it gets scary like in here. And I'm like, no, it's scary way over here. Like, this is the peak when things start to fail. That's where it gets scary, way up here. Yeah.
I mean, like in grade school when they make you run outside.
Yeah.
You're like really cold, and then you start to get frostnip on your fingers. And
Yeah.
you're shivering.
I'll bet your temperature is still above 95. I don't know, admittedly, but I'll bet you. There you go. I heard this so many times. Cardiac arrest, they're not cold. And then, honestly, usually it refers to submersion. Like if you pull somebody out of the water, we're thinking, okay, maybe we wouldn't ordinarily have worked a person because of the amount of downtime, but because essentially they fell into cold water, we're going to give it a try because it will keep them in stasis. But it doesn't mean essentially that all people. You should also know, essentially, that infants do not have the metabolic capability of shivering. And that is where the tricky test question is going to come. It'll be something like, you have a 6-month-old who isn't shivering with a core temp of 96. What should you think? And you're going to be like, moderate hypothermia. They're not shivering. And I'm like, yeah, but their temperature is 96. That isn't even mild hypothermia, and they can't shiver anyways. You see what I'm saying?
They don't shiver even when they're severe.
Well, you've got that backwards. You only shiver if it's mild. You can't shiver in moderate or severe. Infants, or young infants, honestly, never shiver. Yeah.
So,
I don't know why I keep getting everything backwards.
what age infants, right?
1, less than 1. Mm-hmm. What up?
I'm confused. Didn't you just say not to look at the numbers because you're?
I didn't say don't look at the numbers. I said they're hard for me to remember.
Then why would you put them on the test? Like you're saying that you're gonna put the temperature or whatever on the test.
Yeah.
But since you don't remember, they might be wrong. So don't.
Well, I'm not going to put a wrong question up there. I'm just saying it is important. Like, it would be like saying, I'm not saying that heart rate isn't important. I'm saying that you should use their heart rate to kind of guide your thinking, but really mental status is a far greater concept about just perfusion in general, I think. And so even though it's tough for me personally to remember those numbers, because all I remember is 95 and 86 because they're the most significant to me, I'm saying, or what I said earlier was that it will be part of the key that unlocks the question, not the only thing. And where that can come into play for sure is knowing full well that an infant, young infants can't shiver, and so you can't gauge that as their capability of whether or not they're suffering a hypothermic injury specifically. So I'm not saying that you shouldn't use numbers. I'm saying they're hard for me to remember. Yeah. Essentially, they're in development. They don't yet have the processes that involve a widespread shivering response. They just can't yet. They also can't walk. They can't talk. They can't do a whole lot of things. They don't pay bills. Dude. So yeah, all I mean to say is that I think the best way through it would probably be to memorize the numbers. I just never have. What I care most about is things that occur less than 95 and 86 specifically, because it governs how I use epi. Now, in talking about all of these thermic issues, these temperature ranges, these widespread presentations, that's all systemic cold problems. These are references to local cold injuries. Like, you can be a person, essentially, that is hypothermic to the tune of 92 degrees, but isn't having frost nip, chilblains, or immersion foot. Now, you probably do, but they're separate issues. One is about your systemic processes. The other is about your tissue presentation, largely.
So they're of inclusion, not exclusion?
Right, exactly. Yeah. Like if you said, Mr. Fearon, what's the odds I run, butt naked across a field full of ice or whatever and don't get any of these? I'm like, okay, minimal. Yeah. I don't mean to say that you will often see them separate, but they are different processes. Frost nip specifically is generally your brief exposure. I'm sure we've all gotten. Well, not all gotten, but more of us are likely to have experienced a frost nip issue. In a way, I kind of view these like first degree, second degree, and third degree burns. That frost nip is kind of like your superficial sunburn. You just get redness on your ears and nose and stuff like that. That's usually where you're going to see the frost nip. Chilblains, essentially, blains, which isn't second degree burns or anything, is now when you're starting to have that prolonged exposure. But more importantly, chilblains isn't just the redness, it's literally an inflammatory process, sometimes called cold rash. So chilblains specifically is more about the inflammation than it is the literal tissue being chilled down in that way. You're having a reaction to it.
So what's like the main differentiator? That one is just longer. Like you have to be.
Well, the exposure is usually part of it. Like you don't usually just kind of walk to your car and get chilblains. Right, okay. But what happens with chilblains is that the coldness is enacting a immune response, but it's definitely inflammatory response. What I'm not sure of is if that's what my son has. Because we just say that Gummy is allergic to the cold. Like, if you put a ice cube on his leg, he will break out in hives. We took him to the... Yeah. And if he swims in cold lakes and stuff, we give him Benadryl. Like, if he stands in front of a cold air return, he'll break out in a rash. I don't know if that's chilblains. I don't think so. I think chilblains is more of a more hypothermic emergency, not just having a reaction. We talked to the doctors. It was a weird conversation where they were like, it's not immunological. And I was like, oh, okay, so it can't kill him. And they're like, no, you can go into anaphylaxis. And I'm like, you can go into anaphylaxis, but it's not immunological? I'm like, is it anaphylactoid? Is that what you mean? And I'm like, I think he stopped knowing what he was talking about a while in there, but in any event, I don't know that that's the same thing, because if you said to me, Mr. Farron, what is chilblains? I'd be like, oh, it's cold that makes you have a rash because of inflammation. That's what I know.
Do you just get a rash in that specific spot, or do you
I don't know.
break out in rashes?
I don't know a lot about it. My guess is it's localized, that it's not. But any like immune response, I don't know if that can cause a systemic issue, but I wouldn't expect a guy to have feet like that and then me dig through his body looking for the other parts. So I'm gonna guess it's local.
Do we know why the inflammation occurs? Like if it's...
No more, I don't know why, any more than your body is reacting to the process. It'd be, to me, in a certain sense of saying like, well, why are some people allergic to strawberries? And I'm like, well, because their antigens are reacting or overreacting in a way that I don't. So I don't know. Immersion foot is less about the cold, though that is part of it, and more about the water. You'll see this largely in trench warfare back in the day. That's why they call it trench foot, essentially, as they're all standing there in the water, and it's just causing tissue breakdown. Now, part of this is the cold, but like I said, a lot of this is just the water. Like having water move over or drip on something is a profoundly destructive process. I've seen really cool videos about erosion where people are like, oh, it looks like this stone has been eroded over millions of years, right? And then they'll go to somebody's basement where a pipe has been leaking for 60 years, and it's just this enormous cavern and through the concrete. And it's like, dude, it was only 60 years did that. Water is wild. So anyways, the point is that water, and certainly in mix with the cold only making it worse, that's when you're really gonna start to get tissue breakdown. Think of it like, well, if I stay in the tub too long and I get wrinkly fingers, imagine you stay for even longer than that and it literally starts breaking down the tissue. Your body will have trouble separating itself from the water and will have all kinds of infusion and necrosis develop. Now, all of those things we just discussed are at worst cold tissue. This frostbite is where we're having frozen tissue. This is your 3rd degree burn parallel. 2nd and 3rd, I guess I should say. So unlike burns, essentially, that are broken down into 3 categories, this kind of just has like the redness on one side and then blisters, waxy, black, and white on the other. This is infarcted and largely necrotizing tissue. It's literally freezing. That means it's damaged and dead, and that means it's likely to never come back. The book said something cool about how like even a surgeon won't know how much of this tissue is actually gone. You look at these blackened, white, waxy fingers, and he's like, it depends on the microvasculature in there. If any of it's still alive, then it can reperfuse, but we'll wait a couple of weeks and see if your fingers ever come back. They may not, right? So just be careful here, because I think what sometimes people think is like, oh, it's kind of like, hi, what up, dog? I didn't know you're coming in early. Well, I guess it's 11 already.
Just to take the test.
Yeah.
What do you get?
Huh?
Just gonna watch lecture, take the ACL lesson.
Learn. Big learning. Well, that's good. It's 11 and we're...
Is it really good?
Is what really good?
I don't know if you were being sarcastic there.
No, it's not great at all. We definitely aren't doing anything immunological. I was like, what is he doing here? Oh, it's almost time to stop. That's why. So with hypothermic treatment, essentially, we want to remember this. I'm going to say it, you say it back to me. Hypothermia.
Hypothermia.
Passively warm.
Passively warm.
Good job. Remember that. It's still a weird backflip of language. If we've got a patient here, one of the most important... Do I have a little... Yeah, okay. I do. We want to perform this very cautiously. This is kind of like people coming back from a cardiac arrest state. If you got ROSC on somebody, it's not time to speed up, it's time to slow down. Take a chill pill. Not in this case, don't take a chill pill, just a regular pill. Yeah, take you a warm pill. Now, one of the first things that we want to do, other than being cautious, is get them out of the environment. What good would it do, essentially, if I show up, this dude is on the ground and his wife is just administering heroin to him as he persists in cardiac arrest? One of the first things I would say is, ma'am, please stop, right? Or at least some version of that. So getting them out of the environment is super important, right? Removing their wet clothing is super important, right? Because not only is it bad to be cold in that regard, but it's also going to be sapping heat out of them. Once we get that clothing off, then we're going to add layers. We're going to add warm packs, being cautious. Warm and cold packs never applied directly to the skin. That's a big, registry loves to ask about that stuff. You don't apply these hot and cold packs directly to the skin. We can also use warm fluids. That one should come with an Warm fluids in some instances are prohibited by protocols. They won't let people do it in the field. So I would be somewhat cautious of that. I'm pretty comfortably, I checked Georgia's protocol allows EMTIs to administer warm fluids. So I'm pretty comfortable just teaching you that as a standard. But I bet you wouldn't have to cross many state lines to find AEMTs or even medics that weren't allowed to give warm fluids. Yeah.
Are there drawbacks to moving them up too quickly, kind of like the febrile series?
I'm glad you asked. That's why we perform it cautiously, because we don't want to, and that's why I have the turtle there, is to remind you that if they're cold, we move slow. We slowly warm things up. Now, what that largely means is I got a dude, in a hypothermic emergency, I'm going to get him to the truck, get all his yucky stuff off, put blankets on him, and then start heating up the truck. But we're going to take it incrementally. If they're too hot, it's the exact opposite. I'm like, cool them down as fast as possible. Cut them clothes off, spray them with water, blow across their chest. Maybe not the last one. You do that with your partner. Yeah.
So with the warm IV fluids, I've never really heard of that. Is that something that would be prepackaged in the truck?
No.
I think they have a heater.
Honestly, I used to put them up on the dash so the sun would hit it. Some fancier places have little boxes you can put them in. Metro has little, where you keep the NART box, there's a heater in there.
Turkey Fire has a heater.
Sure. Yeah, you just want to be careful, essentially. The biggest thing is I don't need them hot. I need them room temperature, because this person is we want to slowly warm it up. So I don't want to inject it. This is just your reminder, essentially, to not apply heat packs directly to people. And when I say apply heat packs, basically how this would go is I would take a heat pack, crack it open, wrap it in a sheet or a towel, and then I'd put it essentially either under their axial or in their inguinal, right? So where their parts meet. Yeah.
So how would you turn the temperature on the warm IV fluid to make sure it's the temperature?
I would I wouldn't. I'd have to check the room. What usually happens is the back of the ambulances aren't heated while you're staging, and so they're below room temperature. That's all. The only emphasis I'm trying to make is if you were, for example, at a service that didn't have heat and didn't want you to have the back heat on all day, I'd say, well, wherever you are sitting, just put your fluid in there, because it's probably closer to what you need.
I think it's not about being warm, it's about not be cold.
Okay, yeah, I'll take that. I don't need to make sure that you are 98 degrees. It's just the fact that you're 92 will kill you. Sure, I like that emphasis. A couple of considerations here. It's so funny to kind of watch people move people, cover them up with blankets, and then lay them flat on their back on a backboard, which is just sapping all their heat through conduction. So just be mindful of that. If you're going to put somebody on a backboard in a hypothermic issue, it's not uncommon to just lay a blanket, or it shouldn't be uncommon. No rubbing, essentially. When we get cold, we kind of rub our hands together to help generate heat. We don't do that if people have hypothermic injuries. Why? Because if they're having tissue problems and I rub it, I might tear their tissue off, right? Is that a question?
It's about the last bullet point with IV.
So dysrhythmias can be common. As our metabolic process is slowing because we're so cold, it's not uncommon to go into bradycardia. It's not uncommon for it to be so unstabilized in that metabolic process that you start having dysrhythmias that are irregular. This is important. What are our pulse checks for a normal cardiac arrest? No less than what? No more than what? No less than 5 seconds, no more than 10, right? With hypothermic, we're checking for pulses up to a minute. They can be very difficult to feel. A lot of people are confusing slow, weak bradycardia for pulselessness, so just be mindful of that. We withhold epi below 86 degrees. That's why that's the other number I remember. That's an AHA protocol. That means if I check a temperature on a guy and he's at 85, not only do I know that he's suffering from some major hypothermia, I'm not even going to give epi, and that's largely for two reasons. Well, I guess it's one reason. The reason is if you're in cardiac arrest, your perfusion is minimal, meaning your fluid's not moving a whole lot. Not only that, but your metabolic processes have ceased. That's largely, or are ceasing, which is largely the issue. If you're cold, basically what happens is if I give you 3 epi, it stays in your system until you get warm enough to start metabolizing, and then you get 3 epis all at once, which can be a different issue. In any event, we're withholding epi if they're below 86 degrees. Now, what did I say about warming people up? Passive or active? Passively warm people. The term actively warming them is what they call a fluid lavage. Essentially, that's where you go into the hospital, they drain out all your blood, they put it in a microwave, and then they put it back in you after it's warm. So, I've seen on testing before, your patient is experiencing a hypothermic emergency. What should you do? Passively warm, passively cool, actively cool, stuff like that. Make sure you know that term, that we essentially don't actively warm in the field. I think this is becoming dated information, but I think the emphasis is still, look, I don't want to even imply that you're actively doing something aggressively. Take it easy, take it easy. We don't want to cause a dysrhythmia. And it happens too. People will be like, it's cold, we got to get out of here. And they start ruffling them around and grabbing them. I'm like, oh boy, please no, let's take it easy. Now let's talk heat emergencies, or what I like to call hemergencies. These are falling in three categories as well. The first is heat cramps. This is your spasm, right? This one, if you've ever accidentally been an active human, you might have experienced already, right? Basically what's happening is you're working past your metabolic stages, right? As we're not breathing fast enough to keep up with aerobic metabolism, you're starting to experience electrolyte shift, and it can cause spasms, largely around the potassium and calcium in your body. In fact, what's a carpopedal spasm? Yeah. Carpals in your pedal spasm? Yeah, that's right. That's right. Does anybody know why that's happening? Yes, hyperventilation. We can go a step further too. Yeah, kind of. Yes. Yes. What, Alanis? I think calcium. Yeah. Yeah, basically when you're hyperventilating, you're pushing out too much CO2. It changes the pH of your blood. That affects the way calcium is used to depolarize your muscles. So essentially, you have muscle contractures because your pH is changing because of your respiratory pattern. So that's heat cramps in a nutshell, not carpal spasms, but rather, you working so hard, essentially your electrolytes getting worked up. A lot of these heat emergencies are just give them some fluid and keep them hydrated. With geriatric patients, that happens much faster, the issues. In heat exhaustion, this is where we're starting to be hypovolemic. Just be careful here. It doesn't mean necessarily hypotensive. How could a person be hypovolemic but not be hypotensive? Sweating, they're on the way. Yes, kind of. There's a word starts with a C. They're compensating. If I shot you full of holes and you started leaking fluid, your heart rate would go up. Your vasos would constrict, right? That's why that test question about, what's one of the earlier signs of a perfusion issue, blood pressure, heart rate, they can be tricky because they can be compensatory mechanisms or compensated for. Mild confusion. So this is tricky. I think, honestly, that if you ask me what the major distinguishing factor between heat stroke is, I would say altered mental status. And then you would say, yeah, but the book says mild confusion for heat exhaustion. And I'm like, yeah, but it says mild confusion, which I wish it didn't. I mean disorientation. I mean a guy that's like, I don't know. And I'm just like, all right, chill, relax, we got you. Everything's all right, you know?
It can also like stop sweating. Heat stroke.
Heat stroke, that's tricky and we'll talk about it. So here we are again with this pattern. Can you see how heat exhaustion, they may be hypotensive, they very likely will be tachycardic. If I get a guy suffering a heat emergency and he's not tachycardic like he should be, what am I suspecting? Yeah, decompensation. I go over, this guy's sweating, he's having a hard time and his heart rate is 80. And I'm like, oh, thank God. No, 80 is on its way down from where it should be. See what I'm saying? If his heart rate is 80, he's either gotten much better or gotten much worse. And if he's still sitting in the sun, he didn't get any better. Right? Now, heat stroke is the one you die from. The mortality of this is around 10%, even with timely treatment, meaning we don't see that a whole lot. We don't get a lot of people that die of heat emergencies. But if you do, if you saw it 10 times, one of them's dying no matter what you did, statistically. Delayed heat treatment causes a substantially higher mortality. That's part of the reason we're not seeing it as often. You got to get real hot to die, and I should know. Somebody explain to me what thermolysis is. Yeah, breakdown or at least release of heat, lyse to slice, right? Heat stroke means we are experiencing organ damage. This is most notable, I think, by the fact that they have substantial altered mental status or level of consciousness. The reason I didn't include dry, hot skin or inability to sweat on here is because I know that you will get tricked over and over and over by that concept. Right? Like, let me take this right here. Well, this is your mouth water, so let's go ahead and put your hand over there, right? Okay, so she's got water on her hand, right? If that was sweat, the question would become, is she sweating or did she sweat? And so what happens is people come up and they'll be like, oh, well, they're covered in sweat, so they're not in heat stroke yet. And I'm like, you don't think the fact that he's 105 degrees and he's not breathing means that maybe he's suffering organ damage? And they're like, yeah, but he's still sweating. And I'm like, wipe off their forehead, it will never come back. And that's my big point and why I'm careful to even include it here, because I know that it'll trick you up if I put on there that the number one thing is that they can't sweat. Now, don't get me wrong. It can be a rule of inclusion. If I show up and you're in the middle of the heat and you're not tachycardic and you're not covered in sweat, you are either in the greatest shape of your entire life or is suffering a medical emergency. You see what I'm saying? And so that would be my significance, that it's more to the point of the altered mental status indicative of our brain getting an issue, not necessarily the dry, hot skin. And so here's where that largely falls. But we know that that falls there because, again, if you're keeping track, we're starting to see compensatory mechanisms here and decompository mechanisms here. The big one would be the altered mental status. I've seen a bunch of people with 104 over 104 temperature that did not appear altered, by the way. Just brain cookingly hot, mostly okay. I found a couple of other images when I Googled sweating. It wasn't this one, but this is the one I picked. Seemed most appropriate. This was just my reminder to say, hey, if you're not sure if a patient can sweat, wipe the sweat off. If it comes back, that means they can do it. Yeah.
Did you do that like on the forehead?
Always on the forehead. Honestly, I did it very frequently, even with non-heat emergency patients, because I wanted to know if they were actively sweating or not. I'd just walk up and some guy would be like, oh, my chest, and I just quickly wipe across his forehead while I'm checking his pulse and his ABCs. And if it came back, I knew he was actively suffering, he was actively having catecholamine response. In short, I always kind of looked at it like, if a guy has fluid appearing on his skin, it's his body moving it around for some reason. Why is it doing that? Here we are with hyperthermic treatment. I put the rabbit here to remind you that if somebody's real hot, we move fast. It's true at work and it's true in love, right? Now That shouldn't say perform cautiously. Oopsie. Ignore that.
Perform recklessly.
Yeah, reckless abandon. It should say perform aggressively. Be careful there. Poops a daisy. We want to remove them from the environment. We want to adjust the climate. We want to remove those layers. Are you seeing a pattern here in the treatment modalities between hot and cold?
Opposite.
Yeah, they're identical other than the direction. I find it somewhat frustrating they refer to one as active and the other as passive, even though they're largely identical processes. I'll give you a summary, right? So here you have active cooling and passive warming. And as you can see, they are very different experiences. No, they're not. Both of them involve leaving the environment. Both of them involve adjusting the climate. Both of them involve removing layers. In this case, we're adding layers over there. Both of them involve thermic packs. Both of them involve heated or cooled fluids. What we call one active and the other passive. Be careful with that language. The only thing I can think of is, number one, they don't do that. I'm just old and didn't realize they changed the language. Or number two, why am I holding three fingers up? I don't know. Is that they want to further and state that the passive warming, just like easy, 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 actively cool. Cool. Take a quick break, talk about some submersion stuff. Oh, let me pause my thing. Now with submersion injuries, once called drowning and near drowning, now largely just referred to as submersion injuries, some of the major things that we need to discuss is how if you get anything down in your larynx, it's going to slam shut. Suppose that one will write itself. But in any event, the laryngospasm can occur largely to prevent you from drowning, right? If some water gets splashed back there and your lungs would fill up with water, that's real bad. So the solution is close the hatch so no water can get in there. What else isn't getting in there? Air, which is somewhat important, right? Also, obviously, submersion injuries come with hypoxic and hypothermic issues, and then also ARDS. Could somebody summarize ARDS for me? Yeah? You about to read on there? Well, see, this, why aren't you all more like Sam? I know. Every day in the mirror. It's like 10 minutes of me yell. I don't ask, I just yell. You're nothing like Sam. You'll never be like Sam. Yeah, I can never go back. Okay, ARDS is interesting. If I asked you what the cause of pulmonary edema was, I want you to say congestive heart failure, and then for one of you to raise your hands and say, well, also drowning, right? And I'd say, oh yeah, you could also drown. That could cause pulmonary edema as well. Generally speaking, if you're not having congestive heart failure and you have pulmonary edema, it's called ARDS. ARDS, it's like the pirate form. Non-cardiogenic pulmonary edema. Edema is fluid in the wrong place. If you suck down a bunch of pool water, it will cause all kinds of issues. Firstly, it's going to wash out the surfactant. Why is the surfactant important? Surface tension, alveoli stay open. If your alveoli start collapsing, they will atrophy. The vasculature there will start to die. Inflammatory processes will develop. All kinds of things will be problematic. What's interesting here is the point is that if you get a kid that falls face first into a bucket of water and then mom calls because he wasn't acting right, she thought he was drowning, you get there and the kid is fine, you should still tell them to go to the hospital because secondary drowning issues are very, very real. If he sucked down a bunch of water into his lungs, it might take 24 or so hours before fluid starts shifting due to the osmotic pressure. I'm so sorry I bothered you guys. John is fine now. He's breathing okay. I just got worried when he was blue, but he's okay. I understand, my dear. Well, let's hang out while we go over to the hospital so he can be checked out. They might even ask him to stay overnight. He's fine. I don't want to do that. Well, ma'am, you have all authority and ability to be really, really dangerous and wrong here, but I recommend you listen to me. Look at my glasses. I read books, you know? The point is that if I have fluid there, it's going to cause an osmolarity differential, and fluid will leave your vasculature going into your lungs and drown you. And so we have to be very cautious about drowning patients doing refusals because it might cause them a problem tonight. So even if she said, no, that's crazy, I'm fine, I would say, okay, then you stay up with your kid and he sleeps next to you and you listen for choking and bad sounds, my dear, but you definitely need to go. Landon?
Is non-cardiogenic pulmonary edema only caused by drowning, or can it also?
No, it's primarily caused by inflammation, and drowning causes the inflammation, the lack of surfactant and stuff. So that's an important distinction I'm glad you made. So you can get ARDS from a million reasons that aren't pulmonary edema, but they're all, that aren't drowning, but they're all in relation to inflammatory processes causing it.
So could an infection also?
100%.
Okay.
Yeah, pneumonia can cause pulmonary edema. Why? Because it's the inflammatory process and the destruction of the alveoli is causing pulmonary edema. It has nothing to do with your heart. I am very okay with you saying that pulmonary edema is solely caused by cardiogenic issues. But if you get a guy who's got chest pain and a fever with rhonchi and crackles bilaterally, that's ARDS.
What's your treatment for? Just supplemental O2?
Antibiotics, fluid,
Okay.
cure the disease. Be aware of the diving reflex. This largely isn't just when you get water on your face. Usually it's cold water. It's essentially just oxygen hoarding. Your body's saying, like, wait a second, we just jumped into a place that is way too cold. It's time to preserve life. This causes widespread peripheral vasoconstriction. It intentionally, why would it intentionally slow your heart rate down? Isn't that a little counterintuitive? Slow your metabolism. What little oxygen you have, we're going to hold on to longer, right? Very good. Ooh, we ready to talk about some physical laws? You thought you had it bad with Starling. Should have stayed home. Should have stayed in EMT. You're in luck. I know all about this stuff. Good luck on the test. I'll be fine. Henry's law largely involves gas solubility. Boyle's law is largely the relationship between pressure and volume. Dalton's law is stupid. And it involves partial pressures. Got it? All right, now let's talk about snake bites. Here's how I remember Henry's law. You guys ever drink Henry's Cola? Well, it would have been convenient. I don't think it exists, but that's how I remember it. Henry's law largely revolves around the idea of gas being dissolved in a liquid, right? Carbonation in your Coca-Cola. Next time when somebody cracks open a soda can and that just fizzes out, you're like, boom, Henry's law. And then all the girls are like, oh, wow, he's so smart. Right? Specifically, what we're going to talk about is the involvement of nitrogen. Heads up, if I ask a question about nitrogen, it's probably involving Henry's law specifically. Boyle's law is usually just air, whereas Henry's is more about nitrogen causing us an issue. Boyle's law largely about air in general. Dalton's law is dumb. That's why it gets a dunce cap. Poor Dalton. Now, like I said, Henry's law largely involves gases and liquids. Specifically, this means that the higher pressure, the more gas goes into the liquid, which is why when you open up a Coke can, that gas escapes because you are decreasing the pressure. More pressure, more gas in the liquid. You with me so far? Henry's law largely explains why decompression sickness happens, the bends. If you dive down, as you're diving down, the pressure is increasing, right? Because submarines collapse under pressure, right? As you dive down, all of the gases in you are starting to dissolve easier in the fluids. Now, when I say that, you think, oh, right, in my blood. That's not the problem I'm talking about. I'm talking about the fluids in your organs. What I'm saying is that as you dive down, those gases diffuse into your brain and other organs more where they shouldn't. So if you come up super fast, or if you come up super fast and don't give time for that gas to dissolve back into that issue, you're going to have a problem. Now, it's not usually lethal, but it's deeply uncomfortable. Basically, 70-some% of the air we're breathing is nitrogen. And so when we go down in the water, or go down into the depths, more nitrogen is dissolving into our brain and tissues than it should. It's also going into our blood, though I said that's not a large motivator. And that's why we can get some blocked vessels, these cramps, and issues like that. Usually these kind of patients are, like, I can't think of a possible bends and decompression emergency that isn't some dude who then immediately tells me, oh, I was diving today. Right? There I was, accidentally 100 feet underwater. I forgot to mention that. Can you hand me that oxygen tank? So usually this is people, the question you will have is not, is this a diving emergency? The question you'll be is, okay, I know they were diving, what is the problem? And it will either be because they had a rapid ascent or because they didn't blow out enough, but we'll talk about that. So Henry's law is associated with the bends. Boyle's law is a different issue. Boyle's law is less about gases dissolving into liquid and more about the inverse proportion of gases and pressure. More pressure, less volume. A sub goes underwater, pressure increases or decreases?
Increases.
It goes down deeper, pressure increases or decreases?
Increases.
It goes down super, super deep, pressure increases, decreases? When it increases beyond its capability to stay open, that volume collapses. The inverse of that is also true, well, not the philosophy, but meaning as I go up a mountain, right? Do you remember my talking about balloons? That's why Boyle's law gets a B for balloons. If you really like big balloons, you ought to take one up a mountain. They get bigger. Boyle's law, big balloons. See the association I'm making? What's happening, of course, is unlike going down in the water and pressure increasing, going up a mountain, the pressure is decreasing, which means the volume is going to do what? Increase. Your balloon will get bigger. Now, it's still the same percentage, right? Like if I take in 500 milliliters tidal volume at sea level, then I go up on top of a mountain, I'm still taking in 500 milliliters. But because there's less gas, those gases take up more space. That's what we call thin air. If you look here at this balloon, let's just say that this balloon is 1,000 milliliters of air. And so I put my mouth up to it in a weird way, and I suck down a tidal volume breath. That's about 500 milliliters or half of this volume, half of this balloon, right? If I go take that same balloon up a mountain, it's now, let's just say 2,000, I don't know what the numbers would be. Let's say it doubles in size. I still only breathe 500 milliliters, but now those oxygen molecules are spread out. Now it hasn't changed the percentage. It's just meant that those oxygen molecules are spread out. Would that make it harder to breathe? Why would that make it harder to breathe, even if the same amount of oxygen is in that balloon as what started?
You're going to get less of it per breath.
You're going to get less of it per breath. And that is essentially Boyle's law. Dalton's law is that now that we're getting less molecules of oxygen, they're exerting less pressure. Why does carbon monoxide leave your blood? Give me a hand if you know. Why does carbon dioxide leave your blood and go into your alveoli? Why? Okay, gotcha. Landon?
Due to the pressure.
Yeah, can you explain it to me simply? Can you explain it in like a numbers?
It's going from a low pressure to a high pressure.
A low pressure to a high pressure. High pressure to a low. Yeah. If I have 3 molecules of carbon dioxide in my blood, and in my lungs there are less because there's less in the atmosphere, then they will cross the alveolar wall to balance out, right? In Boyle's law, if we're up on a mountain, or Boyle's law would describe essentially that those molecules are farther away. So suddenly my 500 milliliters of air is only pulling in, let's say, 1 molecule of oxygen where it used to pull in 2. It makes the gas exchange harder because it's exerting less partial pressure. And that's Dalton's law. But get back to Boyle's. What law essentially is going to govern the idea that maybe if I... Where's my nitrogen narcosis? I just remembered. That's weird. Death wheel. I don't have it. It's my favorite slide in the whole thing. Yeah, what the heck? That's not great. Well, just imagine Cthulhu. I don't know. It is. Okay. No, I think I deleted it for some reason. But let's take a look back here at Henry's law. Henry's law is talking about gases dissolved in liquids, right? Part of the issue is if I ascend too quickly, that nitrogen will create little bubbles, right? That's not good. Because essentially that gas is escaping too quick. If I dive, the inverse is also true. If I dive down really deep, it's causing essentially that nitrogen to diffuse more into my liquids. So if I take a person and push him way down under the sea, that nitrogen will go into his brain and act like a narcotic. And they call it nitrogen narcosis, like a narcotic. Or what is really, really cool way of referring to is the call of the deep, the rapture of the deep. Essentially, the idea is if you swim deep enough, you're going to get high. And then swim deeper and deeper and deeper because now you're stoned underwater. So Henry's law largely involves the dissolution, the dissolving of these gases. Boyle's law is about pressure. Now, if I dive underwater and I'm going at a nice, easy pace, as the pressure increases, so too will the inverse will happen to the gases in my body. Meaning, essentially, if I've got my lungs full of air, if I take in a breath from my O2 tank, which is actually mostly nitrogen, if I take a breath from my scuba tank, I'm going to fill my lungs up with 500 milliliters of air, let's say, right? Or at least a breath of air. The deeper I go, the more that gas compresses, and quite frankly, it's not the biggest of deals. Does anybody know why my scuba tank involves mostly nitrogen? Why it's not 100% oxygen?
Because as you go down deeper, you're going to need different formula of air to balance out the pressures you're at.
If you just said, well, wait a second, why don't I just use oxygen? That's what I need most of all. If nitrogen is causing me a problem, why would I do that? Because oxygen under pressure will cause oxygen toxicity in you. And so if I'm not breathing in 71% nitrogen, which my body is used to, under great pressures, that oxygen will start poisoning and killing my tissues. Now the issue is that if I take a breath of air, as I ascend, is that, like picture a balloon inside of me. I take in a breath and that balloon inflates. I breathe out and that balloon deflates, okay? The lower I go down, when I take a breath of air, it's compressed in there. It's actually 2 balloons in one now because I'm so deep in the water. If you hold your breath while you ascend, the gas will expand beyond your lung capability. And that's what POPS is. Pulmonary overpressurization syndrome is you not exhaling as you ascend and your lungs pop. Now, it's not always so dramatic as like kaboom and a big chunk of your lung blows out. What can happen here is your alveoli are bursting. And so POPS is revolving around Boyle's law because the gas is expanding, you're ascending too fast, and as your alveoli break, it starts causing the bleeding of those capillaries and alveolar destruction. You start getting subcutaneous emphysema. An air embolism is usually what results from POPs. Now, the issue might be is a guy ascends, he exhales and thinks, oh, I'm fine. And then 10 minutes or so, he's like, oh man, I feel so weak. He's like, I did all the right things. What he doesn't realize is a couple of his alveoli might have burst, released that air into his capillaries instead of his respiratory tract, and now he's got a clot going around full of air. So air embolism is usually the result of POPs. The timing of this stuff can be important. POPs often felt immediately, right? An air embolism takes a bit to brew. The bends takes a bit longer. And if you get on a plane, because you're changing the pressurization as you go into a plane, it can take a day or so. So sometimes the timing can help you through it. Now what we're talking about here in part is this pulmonary overpressurization syndrome, POP burst lung, is causing pneumos. It can be. If you don't die from an air embolism, then you might have air escaping your lungs and causing intrathoracic pressure to build up, collapsing a lung. It's important for you to be able to distinguish early signs and late signs, meaning when a pneumo becomes a tension pneumo. Yeah.
Is it possible for an air embolism to get into the brain and cause a stroke?
Yep, absolutely. Air embolism, like any other embolism, can cause all this. It can cause a heart attack, can cause a pulmonary embolism, can cause a stroke. Location, location, location. Chest pain, dyspnea, unequal chest rise. Is unequal chest rise best described as paradoxical chest rise?
No.
Why?
Paradoxical.
Paradoxical is more specific. It means not just unequal, it means opposite. Unequal might be only half of my chest rising. Why would that be happening if I had a pneumo?
Because your other lung can't expand.
Because it's not expanding, right? What is happening when I describe a tension pneumo? The movement of my trachea? No.
Air fully collapsed the lung, not putting pressure on the media side.
That's right. A tension pneumo is not referring to your trachea moving. A tension pneumo is referring to tension being pulled on your mediastinum. Your collapsed lung is now collapsing your heart. That's what a tension pneumo is. And the last thing you might see before their death is tracheal movement. So do not be looking for that as your first sign. We should be looking at JVD. Why would JVD be happening? Compression of the heart, right? Specifically the vena cava, for sure. What about hypotension? Why would hypotension be a late sign of a pneumothorax? Because of the intrathoracic pressure. And then tracheal deviation is one of the last things you'll see.
How obvious is it to see unilateral movement of the
Not.
chest?
It's hard for me to see bilateral movement of the chest, let alone unilateral.
Okay.
Very difficult. So again, Dalton's law largely refers to the partial pressure of things. The reason why I always thought Dalton's law was dumb is essentially because I thought, who cares? That's like me saying, hey, I've got 2 red rocks in a bucket and 2 blue rocks in a bucket. Turns out each of those types of rocks are putting the same amount of weight according to themselves. I'm like, duh. The idea is that if 21% of the breath I take is oxygen, then 21% of the pressure in that is from oxygen. I was like, what an idiot. I wish I would have named something. The reason this becomes significant is because as we change elevations, it's changing the partial pressures outside of us, but not inside. Here's a summary we won't get into, but is good for studying. Nitrogen narcosis, call of the deep essentially, not really dangerous unless you just never come back. It's just like whippets, if you remember from back in the day. All you got to do is start breathing. It'll help diffuse that very inert gas, no issues. Decompression sickness, largely revolving around Henry's law. This is from rapid ascent. This is nitrogen bubbles in the tissues and veins. This is your joint pain, weakness. That's the bends. You're hurting at the bends, where you bend. POPs is your burst lung. This is from Boyle's law, the expansion of that balloon. And you get AGE, or arterial gas embolisms, when your lungs break open from POPs. I don't want to spend a bunch of time on this, I don't expect you, I'm not going to ask a question that asks about the feet here, but part of the reason we don't really care about high altitude injuries is because like the highest point of the Appalachians are like 6,000 feet. So you just don't get them here. In fact, I've got a lot of buddies out in the West. Every time I say I climbed a mountain, they're always like, ha ha ha, you stupid idiot. You don't have mountains. You've got hills. Here's what I want you to know for sure, that acute mountain sickness is the beginning. That's you getting goofy because you went up a mountain too high, too fast. That's what acute mountain sickness is. Conveniently, AMS, altered mental status. Your guy's confused on a mountain, I'm thinking AMS. Oh, sorry, acute mountain sickness. If he starts dying from it, I'm thinking we got something else. Now, as confusing as high altitude pulmonary edema or high altitude cerebral edema, conveniently, just look at this. Pulmonary edema, cerebral edema, PECE. One of those is dangerous, the other one is deadly. What this means is that as you start to go up a mountain, if you get to the top of the Appalachians, you might experience some dizziness and maybe some confusion. If you grow wings and start flying way beyond that, you're going to have these pressure shifts causing fluid to go into your lungs. That's a problem. If you go even higher, it will then go into your brain and kill you. That's HAPE, that's HACE. Okay? One of the most important things about electrical stuff, lightning, is the reverse triage idea. In triage, essentially, it's about logistics management. You're not even medical professionals. You're just walking around with a paintbrush, and you're like, not savable, not savable, not savable, maybe savable, right? I mean, you're just walking around allocating these things. You're not even doing medical stuff, not really. Like, oh, my guy's not breathing, adjust, still not breathing, always hated. You know, just like no, just keeps moving. You know what I mean? Lightning is the reverse, where if I've got essentially two people out on a golf course, they're both unresponsive. If one of them is cardiac arrest, I help him first because of how reversible and recoverable it can be. Because largely the electricity running through their body can throw them into cardiac arrest. All they need is a little help getting their heart beating again. They'll be all right in many cases. Does anybody have any idea, essentially, when we go through this sudden and massive metabolic process where our muscles are getting burned up, all we do essentially to help with that is the solution to pollution is dilution, meaning we're going to start IVs and start running fluids in there so they can help all their burned up muscles. And also remember essentially that lightning can often, and electricity comes with exit wounds. You touch something, sure, your finger burned up. Where did it leave your body? That might be a blown out back. Spider bites, rarely deadly. You got to be able to differentiate black widow and brown recluse. How you do that is what they do to your body. Black widow is neurotoxic, your neurons. It causes muscle spasms. Brown recluses is cytotoxic. That means it chews up your cells. So if you get bit by a spider and it's got this big seeping wound, I'm thinking brown recluse because it's just chewing up the cells. If you get this little tiny spider bite and you are contracting or having seizures, I'm thinking black widow because that one went into your nerves. I struggled my whole career wondering about the differences. Then I started teaching it and I was like, why did I ever struggle? That's all that's it. There you go. Know this word, Hymenoptera. It's not just bees, it's wasps and ants. They have to teach us that in Michigan because we don't know what ants are. We don't have them like you do. But down here, you're like, yeah, no kidding. Ants and bees, got it. People are allergic to these things commonly. They're not usually deadly, and we remove them. Does anybody know why we don't remove stingers with tweezers?
Because sometimes they have barbs.
I don't know. They always have barbs, I think. It's because if you squeeze it, it will inject more of the thing that's killing them. That's why I get down there with, and I just, that's right. Enough suction pressure. That's why I should be practicing now. Okay, here we go. Now with snake bites, there's an important distinction to be made here. Pit vipers, so I've literally seen a question on the registry that said, which of the following is in Hymenoptera, and it just had a list of insects. Yeah, dude. I was like, really? Really? With pit vipers, this is 95% of the stuff you're going to see. I don't know a lot about snakes. I put everything I knew about them on this. Pit vipers are hemotoxic. That means if you've ever seen the venom of a snake go into the blood and it just coagulates the whole thing because it's just destroying the blood, that's what pit vipers can do. It can destroy that tissue. Not good. They have triangular heads and cat-like pupils. Generally speaking, they're non-venomous if they have rounded pupils. I said eyes, it should be pupils. Rounded pupils and rounded heads. Now, I'm not often getting close enough to any of these snakes to ask them what their favorite flavor is or inspect their eyeballs. Sometimes people kill the snakes. I'll put it in a box and bring it to the doctor so that way they can see exactly what bit them. I've chased a snake down and beat it to death with a piece of wood. That was pretty cool. One down, boys. Man, was my partner so mad at me. What's up?
Yeah, I was gonna ask what was going on, like, with your vacation.
They're all right. Got bit by a snake. It's a big deal. And she's like, it's still in the room. I was like, I'll find out. I'm kicking stuff over. It's whack, whack, whack. What's up? My partner was like a huge snake fan. He was like, what was the point of that? Who even cares? I'm like, you bitter. You suck. Anyway. Okay, what is concerning is the coral snake. That one will kill you. Now, it is very rare people are encountering these things, but it is possible. This one is neurotoxic and can cause all kinds of issues. I just remember, admittedly, I never remember the bottom part of this phrase. I just remember from Boy Scouts, red on yellow kills a fellow. Again, I don't recommend you get close enough to even a coral snake mimic to start looking for the coloration of it. And generally speaking, if somebody got bit by a coral snake, they're probably not recalling exactly what the pattern and color was. So one of the most important things here is merely scene safety. Be careful. What I will say is that anecdotally, anti-venom to reverse these venomous processes is so profoundly expensive, and it's not often kept at most hospitals, which means if you take them like to Kennestone or whatever, they got to call some dude and then order it and get sent there. And they're not going to do that unless you're dying from it. It's one of the only major arguments I ever had with my wife. My son got bit by a snake on the foot. We didn't find out about it until we were going out to dinner. We were playing in a river. He was like, man, my foot's still bothering me. I said, well, let me take a look at it, son. I was like, oh, you got bit by a snake. Just 2 little holes like a vampire. And my wife was like, we need to go to the hospital. And I was like, nah. And she's like, he got bit by a snake. His foot's all swollen. And I was like, yeah, but unless it goes past 2 joints or is causing some physiological issue, they won't even give him anti-venom. I don't have time to tell you about how that turned out to be one of the most embarrassing moments of my entire life. I did end up being correct. It still almost cost me everything. So listen to your wives. Ugh, so small. What a small, sad little man. Ooh, I can't not say it. I have to say it now. I got in a big argument. This one's just for Rose. I don't know if I've even told it. I tell my wife, I say, they're just going to go to the hospital. They're not going to do anything. She said, well, I'm taking them anyways. I said, then you're going to go alone. And my sister said, nah, I'll take her. Takes her, comes back. On the way home says, you know what Steven's going to say? He's going to tell you, I told you so when you walk in the door. And my wife said, what?
She said, no, he wouldn't.
Not my husband. He's not that kind of man. And what did I say when she came through the door? Whoa, boom. I said, what's up? And she was like, you know, your sister told me you'd say that. It's one of the most embarrassing moments of my entire life. It did suck. I'm just going to spend the next 50 years proving her that I can be that kind of man. That's snake bites. What we do for snake bites is we try to keep them calm. Right? The idea is this. Some venom is going into them, some poisonous thing. I don't want them getting anxious and excited, causing their heart rate to go up and letting that spiral through their whole body. I want that venom essentially to chill, right? Now, incidentally, the reverse is also true. We don't want to use a tourniquet because if I tourniquet the injury, then it's forcing that venom to stay in that area and it's going to kill that limb. So the idea is we just kind of keep them all level. We clean it with soap and water in case some of it's still on their skin. We time the bite so that way we can find out is it getting way worse fast or not. But we don't use a tourniquet and we don't use ice for the same reason because ice will cause an internal tourniquet through vasoconstriction. What's up?
Dumb question. What about fluids?
I would say fluids as indicated. If they're hypotensive and they're tachycardic in a way that isn't fear, then I'd give fluids, but I wouldn't be overtly cautious in any way. With tick bites, ticks are only dangerous if they bit something before you that was more dangerous, like a Republican or whatever No, I don't know. If they bit something with Lyme disease, that could be a major issue. It's worth noting that that meat allergy thing doesn't come from Lyme disease. It comes from a specific kind of tick. That's a common misconception about that. You can tell because he's got a cute little star. He big dressed up for Halloween. Now, Rocky Mountain spotted fever, after you get bit by a tick, essentially can cause this widespread inflammation. They called spotted fever because it is inflammation. It is essentially comes with a fever, rather. And you get this spotted like petechia all over your body. And it's largely involving your endothelial cells and just blood vessel damage. With Lyme disease, is a separate issue, and it can cause this bullseye type rash. It can also affect your neurology. It can get into your facial nerve and cause a degradation of your facial nerve, which will lead to unilateral facial droop. So if you've got a final or you've got a registry question and it says something like your patient has a circular rash on their leg and unilateral facial droop, you might not be thinking stroke. Maybe look at their pressure, maybe look at all these other things. But if I'm taking that patient somewhere, I'm going to say, look, I know you got bit by a tick 2 days ago. I know you have a bullseye rash right now, and I know that this might be a facial issue. I still think we should go to a comprehensive stroke center, because if we're wrong, we're going to be wrong in a way that rottens your brain, right?